Hi everyone, today we are going to discuss about pharmacotherapy of peptic ulcer. Uh, as we all know, peptic ulcer is one of the common diseases that found around us. Okay, it is one of the most common gastroenterologic diseases affecting mainly upper GI tract. A sore that develops on the esophagus, stomach, or small intestinal lining due to the pepsin hypersecretion of the gastric acid as well as pepsin. These are the two types of agents or two type of secretions which mainly leads to the peptic ulcer. Okay, here we discuss about two types of peptic ulcer, that is chronic peptic ulcer, stress ulcer. Chronic peptic ulcer, it defects in the gastrics or duodenal mucosa. When the gastric region gets affected, it leads to gastric ulcer. When the duodenal region gets affected, which leads to duodenal ulcer. Hypersecretion of the gastric acid is the main reason which leads to chronic peptic ulcer. It extends deeper into muscularis mucosa. And another one is stress ulcer. It is acute form of peptic ulcer which mainly occurs in the critically ill patients. That means CKD patients or cancerous patients, and its pathogenesis will depends upon the condition of the patient. Next we discuss about its etiology. Etiology, it involves two causes, that is common as well as less common. Common causes include H. pylori bacteria and NSAIDs. NSAIDs include aspirin, ibuprofen, aceclofenac, such a type of drugs. Okay, less common causes include hypersecretory state, that is Zollinger-Ellison syndrome. It is a rare condition due to the tumor of uh, pancreas, which leads to the hypersecretion of the gastric acid. Okay. Next, viral infections. Viral infections mainly due to cytomegalovirus, radiation, chemotherapy. Chemotherapy, that means not in all chemotherapies, only in hepatic artery infusion. That means direct chemotherapy towards liver tissues in case of liver cancer or colorectal cancer. Okay, rare genetic subtypes, idiopathic, that is some unknown reasons, vascular insufficiency. Sometimes blood flow will decrease towards the legs due to the cocaine abuse or cocaine intake. Okay, that leads to vascular insufficiency. In all, we can discuss about its risk factors. Risk factors we can classify into established as well as controversial. In established, if the patient have any ulcer related complications or if have any other kind of symptoms which may be a risk factor for the peptic ulcer. And in a second one, if the patient is greater than 65 years old, there is a high risk for the peptic ulcer. And next, if the patient consume aspirin, anticoagulant, corticosteroids, bisphosphonates, that is this bisphosphonate is a class of drug which mainly used for osteoporosis or other skeletal disorders, and clopidogrel or selective serotonin reuptake inhibitors. These type of drugs which consumes for a long period of time may lead to there is a high risk for the peptic ulcer. Okay, a selection of NSAIDs is an important step whether a patient should take COX-1 or COX-2. It should be done in a cautious way in the risk patients. Okay, next category we can discuss controversial category, that is it includes H. pylori, alcohol consumption, cigarette smoking, that is, and rheumatoid arthritis. Next, rheumatoid arthritis. It is a rare type of risk factor for peptic ulcer because its risk range depends upon the extent of disability in rheumatoid arthritic patients. Okay, so next we can discuss about its pathogenesis. Okay, pathogenesis involves its hyperacidity in the duodenal portion or duodenal region of the intestine, okay, which may lead to islands of the gastric metaplasia in the duodenal cap. Islands of the metaplasia, it is a type of a tumor or cancerous condition which occur in the duodenal portion, and these lead to the colonization of the H. pylori bacteria and that portion, and which may convert urea into ammonia, which is cytotoxic in the presence of urease enzyme. When the ammonia concentration or conversion occurs, it may lead to the mucosal increase in the pH beneath the mucosal region, and also it from the gastric lumen back diffusion of the H plus occurs, and which may lead to the duodenal inflammation and chronic duodenal ulceration, which may later lead to peptic ulcer or a condition called peptic ulcer. Okay. Next, we can discuss about its signs and symptoms, or otherwise we can say clinical manifestations. A mild epigastric pain, abdominal pain, vague discomfort, or abdominal fullness or cramping. These are the main symptom. That is one of the most important symptom of the peptic ulcer, that is mainly in the abdominal region. Okay, in some of the patients there is a chance of nocturnal pain, that is especially between 12 a.m. to 3 a.m. that awakens the patients from the sleep and disturb the sleep. Okay. Also the pain severity of the pain varies from patient to patient. Sometimes pain occurs seasonally in some patients in the spring or fall, and some patients have the discomfort which occur as episodes in clusters lasting up to some few weeks, and there is followed by a pain-free period. That is, in some patients, pain occurs for a few period. That is, pain occurs for few weeks and followed by the pain-free period. Also, along with the pain, some patients experience heartburn, belching, and bloating, etc. And also nausea, vomiting, anorexia. They are also common with this pain. Some patient experiences weight loss in this condition. Next, we lead to complications. Complications we can categorize into life-threatening, most frequent, least frequent. Okay, in life-threatening complication, upper GI bleeding, that is upper gastrointestinal bleeding, or perforation in or penetration into adjacent structures, that is pancreas, liver, or biliary tract, or if there is any obstructions in the gastrointestinal or abdominal portion, which may lead to life-threatening condition, or which may lead to the mortality of the patient. Okay. Next, we deal with the most frequent complication. It include bleeding may sometimes hidden. We can't find or we can't diagnose that type of bleeding, or in some patients we can diagnose with a melena, that means black colored stools, and a hematemesis, that is vomiting of the blood. Mortality is higher in patients who continue to bleed or who rebleed after a initial bleeding has stopped. That is, if the patient continue to bleed, or if the patient rebleed after initial bleeding has stopped. In that type of cases, there is a high chance of mortality of the patients. And next, we deal with the least frequent complication, which means gastric outlet obstruction. Gastric outlet obstruction means pylorus region get blocked, which may prevent the passage of the food into small intestine. That is the least frequent type of complication. Next, we deal with the diagnosis. Diagnosis we can categorize into two types: laboratory tests as well as other diagnostic tests. In laboratory tests, firstly, gastric acid secretory studies. Okay, And if the patient is unresponsive to therapy, or if the patient has hypersecretory condition, in that type of cases, fasting serum gastrin concentrations are only recommended for that type of patients. Okay, if we take the CBC, we can see that hemoglobin and as well as hematocrit levels are low due to the bleeding. Okay, in stool hemoccult test is always positive for this type of patients. And we can also do tests for the H. pylori bacteria. Next, we deal with the other type of diagnostic tests for the peptic ulcer. First one, fiber optic upper endoscopy, which detects more than 90% of the peptic ulcers by biopsy, visualization of the erosions, and we can see the sites of the active bleeding, etc. By direct inspection, which it only permits direct inspection. Okay, next, radio routine single barium contrast techniques, which detect more than 30% of the peptic ulcer. And next one, optimal double contrast radiography, which detects 60 to 80% of the ulcers. Next, we deal with the management. We can categorize management into non-pharmacotherapy as well as pharmacotherapy. So firstly, we deal with the non-pharmacotherapy. In PUD patients, that is peptic ulcer disease patients, we should discontinue NSAIDs if possible. And in some of the patients, for certain foods and beverages cannot be tolerated, that is spicy foods, caffeine and alcohol. And so in that if the patient cannot tolerate this type of food, the patient should avoid these types of food. Okay, and some of the lifestyle modifications are mentioned here, that is reducing stress and diseasing or stopping cigarette smoking, which should be encouraged. And consumption of probiotics, that is strains of lactic acid producing bacteria such as lactobacillus and bifidobacterium, lactoferrin, and foodstuffs such as cranberry juice, ginger, chili, oregano, some milk proteins. These are some of the supplements which may lead to eradication of H. pylori. And if the patient has ulcer-related complications, surgery may be preferred for the bleeding, perforation, or obstruction. And surgery for medical treatment failures are rarely performed because of the effective medical management. Next, we can deal with the pharmacotherapy. These are the few goals for the peptic ulcer management. Firstly, it depends upon whether the ulcer is related to the H. pylori or associated with the NSAIDs. And also the treatment goals may differ from the whether the ulcer is initial or recurrent, or whether complications have occurred. And the treatment is aimed at relieving ulcer symptoms, healing the ulcer, preventing the ulcer recurrence, and reducing the ulcer related complications. When possible, the most cost the most cost effective drug regimen should be utilized. As we know that all patients cannot afford for some of the medications which have high cost. That is, so there are a slight difference in the if the drugs are from the same category as well, there is a high difference in their cost as well as in case of some of the drugs. So in that case, most cost effective drug regimen should be utilized for the patient. Next, we deal with the two categories which we usually prefer for the peptic ulcer. First one, H2 receptor blockers, that is example cimetidine, ranitidine, famotidine. Okay, usually used for duodenal ulcer, gastric ulcer, stress ulcer, gastritis, GERD, Zollinger-Ellison syndrome. And these H2 receptor blocker, which blocks the its mechanism of action involves the block or inhibition of the H2 receptor, which leads to the decrease in the gastric acid production. And these are the few adverse effects of the H2 receptor blockers: headache, dizziness, bowel upset, dry mouth. And CNS associated adverse effects include confusion, restlessness, and if the H2 receptor blockers are given IV as IV bolus, which may lead to histamine release, that is bradycardia, arrhythmia, cardiac arrest. These are type of adverse effect associated with IV bolus infusion. And also cimetidine has an anti-androgenic action. Next, we deal with the proton pump inhibitor. It is one of the most common agent preferred for the gastric acid hypersecretion, that is peptic ulcer. Okay, omeprazole, pantoprazole, esomeprazole. These are some of the examples. Its mechanism of action involves when the drug gets activated, it irreversibly binds to the H plus K plus ATPase and inhibits its activity. Okay. Also, it inhibits the gastric mucosal carbonic anhydrase. And some of the uses are as follows: GRD, peptic ulcer, bleeding peptic ulcer, Zollinger-Ellison syndrome, aspiration, pneumonia. These are some of the uses. Okay. And next we deal with its adverse effects, that is nausea, loose stools, headache, constipation, abdominal pain, muscle and joint pain, dizziness, rash. For H. pylori positive ulcers, we prefer three types of drug regimen. That is, in first case, a proton pump inhibitor, that is OD or once a day or twice a day, plus clarithromycin 500 milligram twice a day, plus amoxicillin 1 gram twice a day, or metronidazole 500 milligram twice a day. It's one of three drug regimen preferred for the H. pylori positive ulcers. Next one, PPI or H2 receptor antagonist, that is H2 receptor blocker, or bismuth subsalicylate 525 milligram 4 times daily, metronidazole 250 to 500 milligram 4 times daily, tetracycline 500 milligram 4 times daily. It's one of type of a drug regimen, that is 4 drug regimen. And next regimen involves PPI, that is proton pump inhibitor once a day or twice a day, clarithromycin 250 to 500 milligram twice a day on day 1 to 10. Okay, amoxicillin 1 gram twice a day on days 1 to 10, metronidazole 250 to 500 milligram twice a day on days 1 to 10. It is next type of a drug regimen, that is there are 2 4 drug regimen and 1 3 drug regimen. Okay. Next we deal with the algorithm. If the patient have the ulcer-like symptoms, we can diagnose whether it is due to NSAIDs or whether it is due to other causes. If the patient have no alarm symptoms, should check whether it is due to NSAIDs or other causes. If the cause was NSAIDs, patient should stop NSAIDs or decrease the dose or switch to more selective COX-2 NSAIDs. Okay. If the patient symptoms get resolved, no further treatment is required, should follow or should stop the medication. If the symptoms persist, then begin the treatment with the proton pump inhibitor, that is PPI. If the patient resolves with the PPI, then continue the PPI. If the symptoms continue with the PPI, refer for further evaluation. Okay. If the NSAIDs was not the cause for the peptic ulcer, then should check if whether the patient is treated for the H. pylori, should perform serology. If the serology is negative, begin the treatment with the proton pump inhibitor. If the serology is positive, begin the treatment with the eradication regimen. That is, we already deal with the regimens used for the H. pylori positive ulcers. Okay, and in case if the patient have alarm symptoms, that is should perform the endoscopy for ulcer. If while performing endoscopy, if the patient is diagnosed with ulcer, test for the H. pylori, whether it is positive or negative. If it is positive, then should follow the eradication regimen we already discussed. And if it is negative, on NSAIDs, stop NSAIDs and treat the ulcer with a proton pump inhibitor, or continue the NSAIDs or switch to more COX-2 selective NSAIDs. And also treat the patient with the PPI along with the misoprostol. Okay. If the patient have no ulcers, then consider for the other etiologies for symptoms, that is GERD and NUD for that type of conditions. Okay.